Welcome everyone, and welcome to the Aged Care Industry IT Council National Forum, Aged Care on FHIR. We'll just give people a few minutes to log into the system. So whilst we are waiting for them, I'll go through some basic housekeeping for you. From our perspective, all microphones have been muted other than those of the panelists. So we won't be able to hear any of your background noise. So if the dog starts barking or the kids go feral, don't panic. It's all under control from our side. If you have any questions during the event, please post them using the Q&A panel at the bottom of your Zoom window. If you can please use the Q&A panel, that'll allow us to manage the questions more efficiently, and we'll answer those live where possible, or we'll answer them via the Q&A panel. Any questions we don't get around to today, we will endeavour to get back to after the event. If you have any technical issues during the webinar, please post them to the Q&A panel as well, and the technical team will directly make contact with you to try and help you solve those problems. This session is being recorded and will be made available in a few days. So if you want to come back and learn and recoup the wisdom, you're more than welcome to, or to share it with your friends and family. We'll just give people a few more minutes as people are starting to log in, because being early in the morning and down in Perth, they may be just getting out of bed, getting ready to join us. We do have quite an exciting and full session today, so please start asking your questions early so that we can prioritize the questions and get around to answering them by the end of the session. Numbers are starting to pick up, so let's move on. So again, welcome colleagues to our national forum. I'm very excited today as our forum includes world-class experts on three areas I am particularly interested in: geriatric medicine, technology standards, and the business of delivering solutions at the coalface. Our three speakers are all experts in their respective fields, and today we are exploring the confluence of those three areas to provide real-life solutions to the challenges we face in aged care. Whilst we have heard a lot over the last few months on the problems with aged care, there has been little discussion on how we solve them. Today's discussion, I hope, will go some way towards us as the aged care provider industry to research and develop solutions to the problems we face in delivering high quality, safe and efficient care to older Australians. COVID revealed many shortcomings in society, in particular around aged care and healthcare. The tendency of the disease to affect the elderly and the subsequent need for ongoing comprehensive care revealed the disconnect between the aged care system, and in particular the residential aged care system, and the acute healthcare system. There were many factors involved, and no doubt there will be many reviews in the future examining this. However, from a technology and information perspective, one obvious shortcoming was the paucity of information sharing between the two sectors. Whilst this has been noted before in many anecdotal cases, the sheer volume of individuals affected by COVID and the risk associated with its effectiveness highlighted the challenges involved in sharing information between the various systems that captured and used information relevant to this population. The knock-on effect was delays in identifying and triaging individuals at risk, providing them with the appropriate care, and preventing the spread of disease. It also slowed down the sharing of best practice between facilities and prevented the rapid development of evidence-based protocols to battle the pandemic. Finally, it also allowed the growth of fake news conspiracies about the disease, as we did not have, particularly at the early stages, real data with which to challenge many of the fallacies spread through these groups. As we learned more about the disease and its effects, we have significantly improved our data collection and information sharing. However, the lack of standards has led to an ad hoc system developing which has struggled to deliver its full potential. Like with telehealth, the pandemic has been a catalyst for the rapid development and adoption of technological solutions to help solve these problems. Also, as with telehealth, the rapidity of the change has led to shortcomings in governance and designs for sustainability in many of the solutions. For many of us, including our colleagues we are about to hear from, we have been banging the drum about the need for standards for many years. The pandemic has brought the need to the forefront, and many have responded, some with better qualifications and intentions than others. I note that New Zealand recently announced that its Health Information Standards Organisation has set out a detailed roadmap to take the health and disability sectors towards interoperability. Hopefully a bit of trans-Tasman rivalry may bolster our local activity. It's not that Australia hasn't gone down this path before. The formation of NETA in 2005 was to help Australia develop its own interoperability roadmap. It led a number of activities, including significant work in national identifiers and secure messaging. Its successor, the Australian Digital Health Agency, continues that work. The focus on the My Health record, triggered from the Rudd government's 2020 summit, remains at the core of much of its activity. Recently, aged care has played a greater role in that activity. However, I believe that there is much more scope for aged care involvement, and we are in active discussion with the agency at present. I also note the work of the MSIA, who are part of our panel of speakers today, in supporting the local vendor community in developing interoperable solutions. I refer you all to the Council's Technology Roadmap for Aged Care in Australia, released in 2017, for a more detailed discussion on the need for interoperability in aged care and the steps required to get there. Our most recent work, the Care IT study, which should be publicly available in the near future, looks at the status quo in this area and also recommends a number of needed actions to help take us forward. Today, we will be exploring this issue, firstly by hearing from our three speakers, all highly respected experts in their fields and actively involved in developing, implementing and researching the use of standards and technology in health and aged care. This will be followed by a panel session where they will answer your questions and allow you to share your thoughts on the value of technical standards and the best way to implement them in our industry. Finally, we hope to start developing recommendations and actions to help improve the standards, their development, implementation, and widespread use, and design evaluations to support ongoing research to continue the improved delivery of aged care in Australia. And on that note, I'd like to introduce our first speaker, Mr. Grahame Grieve, who will be presenting Why FHIR Matters for Aged Care. Over to you, Grahame.
Thanks, George. It's a pleasure to be here. Thank you for inviting me. So George asked me to tell you about why FHIR matters for aged care. So just a little bit, first of all, so FHIR is an international standard for data exchange. It's primarily a technical standard, and so it fits relatively low down in the stack of things that we need. But I think it's foundational interest. So we go to the next slide. Thanks, Georgie. So the origin of FHIR is something I started back about 9 years ago, based on the observation that healthcare has broken processes. And it's not because any individual is not doing a good job. All of us, nearly everyone I've ever met is operating at the limit of their capacity to do their best. But as a whole, the system doesn't gel together. And what I observed is that other industries were and are being transformed by IT in a way that health is not. And there's a few reasons, and a couple of the reasons relate to technical standards. So the right kind of technical information standards that underlie the transformation of other industries, particularly to integrate the operations that you have for your back-end communication, your B2B, business to business, back-end communications, and your consumer to business at the personal level, so system to person. The standards were different for healthcare and they were diverging. And there were plenty of implementation problems with IT. Well, honestly, I should tell you, it's not really about IT. It's not a technology issue. What our core business is information management and information management standards. And so it's not really technology, but we just call it IT anyway. So it's not technology. I want to be clear at the start that there's a lot of other problems, and I'm sure you can reel them off just like I can. Technology is only a small part of the problem. But we think it's important because a lot of the other problems, you could think about solving them, but you come back to the problem that technology and the information management is just not there. And so they block dealing with the other things. We felt that if we as a community could create a better standard, we'd tilt the playing field and make it easier than possible to solve the other blockers. Those are the ones that actually matter. Technology doesn't solve any problem. So over the next slide. Thanks, Georgie. So just quickly, FHIR comes from HL7. So health level 7 is an obscure reference to an obsolete network model, which just proves HL7's been at this for a long time. And it's a really worldwide, thoroughly connected standards development organization for information management and healthcare. And it publishes a whole bunch of standards, some of which are widely adopted and very old and at the end of their life cycle, and others which are new. And increasingly, HL7's entire focus is on FHIR, and I'm the product manager for FHIR, and I created it. Next slide, thanks, Georgie. So FHIR, oh yeah, this is slide, just go through next couple of, that's it. FHIR stands for Fast Health Interoperable Resources. It just doesn't matter what that means. It's just a gimmick to get a quickly recognizable internet acronym that works everywhere. And it works well for that. And so FHIR is two parts, like a snail and its shell, they're tightly linked. The first thing is that FHIR is a community of people. We meet under the umbrella of HL7. We're dedicated to make it easier to exchange healthcare information and to use the web to do so. And we have a belief that doing so in an open fashion will create transformation of healthcare. And FHIR is also a technical specification. It's freely available on the web at that address. It describes how to exchange information about healthcare, and it basically adds healthcare knowledge to the standard web infrastructure. So those two parts are key to understanding what we are. Next slide, Georgie. It's that combination of open community and open standard that is what really makes a difference. So I'm going to pick a couple of things about here. One is that FHIR is open participation. So really it's the social media healthcare standard. And a lot of the way we operate came out of saying, what does it look like to have a standard in a world where awash with communication and publication tooling, but where the problem is a people problem? How do you get the right people to collaborate and make it worth their time collaborating? And HL7 is a good place for doing that. It's not perfect. There is no perfect place, but good because we're deeply connected to the worldwide health community, whether that's the providers or the vendors or the regulators. And what we produce is an open standard that crucially has deep continuity at the knowledge level, the way information is described with existing healthcare standards. Because it turns out people really care about getting their existing records, keeping them and sharing them. And so whatever we do, we start with people's existing records matter. And that is a huge constraint on what we do. On the next slide. And so a lot of what I do is about not technology or even engineering, but about social, social management, managing the social group. So an open community, anyone can join. And what we do is we argue about everything. So someone comes along and says, I really want to solve this problem. So we have a big bun fight about how it should be best be solved. And then we figure out, at the end of our argument, we write down what we agreed was the least worst way to do things and publish that as an agreed community, as a community agreement. And the thing about it is, because we publish it in public without patents, it's not patentable or copyrighted, it's open source, everybody owns it. Because everybody owns it, everybody can assume that everybody else owns it. And so we have billion-dollar companies coming and giving us their best people to produce community infrastructure, commonality that they can assume that everybody has access to, and then build businesses on it. So in a sense, it's community treasure. We all own it, and we're all richer because we all own it. But a key to obviously to that is having solid governance. And there's a whole bunch of processes we do to prove that if you trust us with your treasure, we'll look after it properly. And that's, you know, a big part of what I do is making sure that that happens. Okay, next slide. So I'm not going to dive very much into the technical details of the FHIR spec. It's just, this is not the place for it. It's a web API, so we use web techniques to exchange data between systems, and API is a general purpose service that other applications can make use of. Technically, we use a set of resources, and there's a set of common infrastructure and rules around exchange. And those resources, which I won't bother describing what they are, they are records that capture parts of the healthcare system process. And then we build on top of that. And so some of the resources deal with really basic things like what's SNOMED, what's LOINC, how do you actually make those deployable into a shared infrastructure? And then there's things like what's an encounter, what's a patient, how do we share information about them? And then there's the core patient clinical record. What's an allergy, what's a condition, what's a problem? What's a lab observation? How do we share those? And some of those we have extensive experience sharing in old technology, and some we don't have extensive experience. How did you get to your diagnosis, for instance? But then we've moved on and said, what's your set of care plans that you actually follow? Why do you follow them? How do you interoperate your plans for providing care? And then finally, on top of that, there's a bunch of decision support stuff built into the how do you manage care layer. And then at the top is, what is your evidence on which you're actually providing care? Are your care plans linked to the evidence? Does the evidence stack up? And so we're heading towards an entirely connected healthcare system that can automatically do evidence-based medicine as an ongoing thing. Now, the further up that stack you get, the more cutting edge that is, and the longer it'll take to become possible. But we cover all of that stuff, and there's a lot of interest in actually trying to close the loop on why are we doing what we're doing? Is it working? For which patients is it working? Okay, next slide. And so why would you engage? People don't get engaged for technology's sake. It's just, I mean, a few people do, but it's not how healthcare works. And so really it's about outcomes. So the web API is capability based. What makes you capable of doing things? And in the old days, when we put up an interface, it would work for the specific purpose it worked for. And if our business interests change, we had to pay to have the interface upgraded. But the new interfaces are actually robust and resilient and adapt or very directly to business adaptations. I think that's a really big deal. A common content model across everything that we do, from engaging with the patients, collecting data from the patients, all the way through to reporting to public health agencies and everything in between. The open license and community, lots of public testing and tooling infrastructure to make it easy for people to get things right. And so those, but above all, it's a culture of try something, find that it works, have open agreements, open processes to get to agreement, and then publish everything openly. Okay, next. So what happens is at the international level, which is the core FHIR specification, we can only put in there what everybody agrees to. And there's a lot of variation around healthcare around the world. And there's variation not only between jurisdictions, but variation, for instance, between a GP, an emergency department, an internist, an ICU, an aged care centre. They're very different perspectives on what kind of data they collect and why they share it and what their shared processes are. And so then what we say is, okay, the base specification creates a platform for all of those to be common, but all the smaller groups are able to get more agreements about how they're solving a particular problem. And so what we have is this cascading layer of smaller groups with better agreements, which lead towards actually working solutions. In some kind of fantasy world, there's a healthcare system that doesn't need that, but I don't know what that would look like. We go to the next slide. So we set out to do three things. One was a technology thing. We wanted to transform healthcare IT standards. And we wanted to make people who provided the standards think really differently about their business model and the way they published and developed and published standards and how they believed that was beneficial and what their goals were. And that's pretty much done. It's not complete, but it's inevitable now that all of the standards providers will function in a, web-enabled, social media-rich world. And we set it to transform healthcare IT. It should be IT, not IG. And to say we want to move away from walled gardens, locked-in vendor systems, towards systems that are interoperable innately. And I could talk for hours about what that means technically, but in the end, it's a business transformation. And that's starting to have noticeable effect. It is by no means done. It's a long way from done, and particularly in Australia, where the government has not exactly contributed to forward progress. Whereas in other countries where the governments are driving forward progress, we're really starting to see noticeable transformation in how people think about their IT systems. But our real goal is to transform healthcare, and that is only just beginning now as we're eating more into those others to start saying your healthcare is better because information sharing is better. It's a longer goal, but we're at the point of focusing on that now. Okay, next slide. So how this manifests to me, what drives me, is the discoordinated care that we have. My friends and family, my elderly parents and parents-in-law, they have this common frustration that comes up again and again. There's gaps in the healthcare system and they fall into the gaps and they turn into casualties in those gaps. And they're scheduling communication problems, conflicting care plans, conflicting definitions of success. My mother-in-law went to the GP. He referred her to a specialist. The specialist put her on medication. She went back to the GP. The GP said, that's not the right medication. Don't take that. That's silly. She went back to the specialist. He said, well, if you're not doing what I'm saying, why are you here for? And I hear that all around the world. And it's very difficult for patients to know how to resolve that. What I'd really like to see is a distributed care plan where everybody who's responsible for the care of the patient is in on the care plan. Massive transformation of healthcare itself and a big upfront investment to get to a much better place. And so really a difficult proposal, but there are trials around the world of actually trying this out in mental health, in renal care, in diabetes care, in a bunch of social care / legal court situations. We'd really love to see this starting to happen in aged care where, my daughter works did work in an aged care facility. And through that, I had all these, classic care coordination issues with the rest of the system that just weren't getting addressed. And so we have built, through our support for these pilot projects, the information management specs to support this kind of thing. And now we're saying, how do we actually build capacity to do this? Okay, so next slide. So in aged care, like I said, there's obviously a pain point around transition to the healthcare system, and we can address that. We can make for much easier communications, and I just finally wrote a public proposal about how to do that in Australia, see if that gets any legs. We can automate referral pathways, which I know is a huge pain in healthcare and people have been talking about. We have all of the management specifications to do that if people want to do it. Integrated medication management, which is not a big problem, seamless care teams. And a particular focus with COVID this year is around getting public health and performance reporting and surveillance much more automated and simpler. And that's happening in a number of countries right now, although I've had zero here in Australia around that. And also there's some attention around billing and payment. I don't know how much difference we can make to those, and I don't know how much, if that's ever relevant. for Australia either. So there's some of the ideas that it seems to me that there's, you know, a crying need for information management improvements in aged care. So next slide. So we set out to disrupt healthcare. Of course, we set out to disrupt healthcare IT, but healthcare is what we care about. We did that by significantly reducing the cost of data exchange. I set out and said, when I first started this, there was this whole bunch of idea around get patients their personal healthcare record and provide a service to them and connect it up to their institution and let them get their healthcare data. It'll be theirs. And then they can share it with whoever they want, and we can build person-focused workflows rather than institution-focused workflows. When I first started doing that, I did a brief estimate of the total cost of the TCO for a PHR to institution hookup. And I got to $150,000 US in USA. Legal fees, sales, development, maintenance, licensing, so forth. So it was 150,000. I said, my stated goal for FHIR is to take 90% of that off so that it's, you know, $10,000 to $15,000. Well, today, if you want to do that, you put up a legally compliant FHIR endpoint. This is in USA. You register with Apple. It costs you nothing. You subject your endpoint that's legally compliant to the FHIR test cases. If you pass the Apple test cases, then you go live. There's like, for most institutions, we're actually 95% or more reduction in cost. And that just, for the same amount of money, it's a huge bang. And it's across the board that we're targeting that kind of cost reduction for data exchange by making it a commodity. We do that by encouraging development of open community and then iterating our improvements. And our goal here is to lead to what's sometimes called Health 2, a different healthcare system. As well, we want to be able to scale computation about how healthcare is actually working. But to do all that, we need community infrastructure at many, many levels. There's a whole pile of things that need to be built on top of what we're doing. So I just want to finish by saying, and I know this is preaching to the converted in this group, but we need a civil society, which is people contributing professional know-how to open knowledge repositories. And so I encourage everybody to join us or some other group that's developing better knowledge. Of course, here we are at a group doing exactly that. So that's preaching the converted. But thank you for listening to me. This is really, in the time, provide a really high-level overview. So I hope that sort of gives you a sense of where we're going and what's important to us. And I don't know how much time you want to give me for questions.
Thank you, Grahame. Thank you. And we'll leave questions to the end. Questions are starting to come through, and there are some great questions. And you know, Grahame makes some great points around the fact that this isn't a technology issue, but we do need to get the technology working in the background to enable the disruptive change that we need to improve the quality, safety, and efficiency of care in Australia. So, and I said, you know, when I was talking about people banging on the drums, I think I first met Grahame in 1997 at an HL7 meeting. So he's been banging this drum for quite a while, and I've seen him around the world banging the drum. And interestingly, other countries have taken some of his drum banging more seriously than we have in Australia. So I think it's very important that we recognise that a lot of the stuff that's happening around the world is being driven by work out of Australia. We just need to basically take some of that work and deliver it locally here. So yes, please continue to ask your questions through the Q&A panel, and we will come back to those at the end of the session to ask all our panelists to answer those. Our next presenter, I'm particularly pleased to be introducing, is Professor Len Gray. Now, I've known Professor Gray for many years through his work in geriatric medicine, aged care, telehealth, and as we now know, the telehealth is the 2020 success story, whereas Len's been working on telehealth back in before the beginning of this century. So it's a long time coming, but the reality is that that work's been needed to be done to enable us to provide the high quality services we are now. Len will be presenting on information challenge in aged care and the aged care data compare project. So I'll hand over to you, Len.
Thanks, George, and thank you, Grahame. It's a great honour to be speaking after Grahame, not only because it's a great honour, but also he's presented a very good introductory talk in relation to what I'm about to say. So I'll just share my screen if that's okay with everyone. So we are working on a HL7 FHIR project at the moment, which I'll talk about shortly, and so that's a really good segue that from where Grahame's been at. Like Grahame, we've been, as George said, we've been beating the telehealth drum here for a couple of decades, and also the work in data standardisation, information standardisation around clinical care of older people. It's another 20-year adventure that I've been involved in. I'll talk about that briefly as well. So, I'll get my slides to change. There we go. So I've got, this talk will be in two parts. The first, I'll talk about the need for data standardisation and interoperability. I won't much repeat what Grahame said. Everything he said, of course, I agree with. And then, but I want to talk more about the data itself. What is it that we're going to interoperate? What is to be messaged? And to think about that in the context of not only what we call aged care in Australia, but beyond the system of aged care into other environments in which older people find themselves receiving healthcare. And then I'll talk specifically about the project that we're undertaking at the moment around data. So if you think about the diagnosis of let's say stroke, it's well characterised by the ICD-10 system. There's a diagnosis-related group for it. There's a SNOMED representation of that. But what about something like mobility? Now, mobility is a phenomenon that's critically important in aged care, and more than the diagnosis, and more than the lab tests, and more than most other things, will drive not only the person's need for care, but the cost of care, the quality of care, and so forth. The mobility issue becomes primary. And how is that described in a way that it can be shared amongst organisations? So this is the beginning of my talk, to think about these phenomena that I call functional and psychosocial problems, how they're characterised and how they would be shared amongst those providing care within an organisation and beyond. So why do we care about mobility? Well, it obviously drives to some extent diagnostics. So if a person has mobility problems, perhaps they've got Parkinson's disease or some other issue some other diagnosis that's causing the mobility problem. That's a more classical kind of medical way of thinking about it. But in an aged care setting, it's going to drive the care delivery. Does somebody need to help this person to walk? And if so, what are the resources that are available to help them to walk? And if they can't walk at all, how do they get about? What resources are available? Mobility also drives risk assessment. The nature of the person's mobility may predispose them to falling, it may predispose them to pressure injury and so forth. So it's got a risk dimension to it as well. We're all interested in maintaining a person's function. We don't want to see their mobility decline. So if we see an organisation where the residents, for example, are declining in their mobility at a rate that we wouldn't think was acceptable, then that would be perceived as a quality issue. So we want to understand mobility for that reason. And then there's the plain simple, let's tell the next care provider or the other care provider what the mobility is so they can prepare and manage their care properly. And finally, I've mentioned resources already, but how do we pay an organisation to provide care? And to some extent, the cost of care is driven by a phenomenon like mobility, and there are many other phenomena like mobility that drive cost. And so there's a whole myriad of reasons to characterise this mobility problem properly. So how is this currently done at the moment? Well, often if you look in a record, you'll see some open text that says Mrs. X needs some help to walk safely. So supervised or assisted walking, or they won't be able to walk at all. Open text is kind of fine if you've got access to that record directly. It won't be necessarily consistent amongst residents the way it's described, but it's okay if you can get at the record. But as soon as you want to describe it somewhere else, you need to somehow categorise it. So often folks will describe this as a dichotomous phenomenon, walks independently, yes or no, and you'll see this in record systems all over the place. There'll be a box to check that the person can walk. The level of granularity of how that descriptor will be highly variable, and the way it's characterised will also be very variable amongst homegrown descriptors. There's a whole variety of mobility and ADL measures out there that will characterise a person's mobility. Some of them I've mentioned that get used in this country, like the Bath Health Index will have an item around mobility. The functional impairment measure, the FHIM, is also another way of describing mobility. And of course, the interRAI long-term care facility system also has a descriptor of mobility. And the RUG ADL component of that is also used in the ACIITC system to characterise mobility as well. So there's a whole lot of ways you can do this, and each of those approaches has some level of granularity, so it will give you more a sense of how the person performs and what help they need. So when you've got standardised data, and I've used mobility as a kind of exemplar, but we can think about continence, we can think about cognitive function, behaviours, we can talk about nutrition. There's a whole variety of these kind of phenomena that are really critical to the person's care. So there's a whole lot of stakeholders that will want to access the information in some kind of standardised format. So these would be obviously care providers, and they're interested from the point of view of making sure that assessments are done thoroughly. The assessment should drive care planning in a semi-automated way. It will then translate into task allocation, who's available, what resources are needed to help that person, and of course monitoring how people are going is another part of the care provision process. Facility managers or program managers want to understand their caseload. They want to be able to allocate resources appropriately. They want to know how the service is performing in terms of improvement, decline, and how they compare to other, within themselves amongst their various divisions, but also with outside organisations. Regulators are interested particularly in quality monitoring and very interested to know that the folks that they're paying or regulating are delivering high quality care. And of course, the payers want to know who's out there, who are they paying for, what kind of level of payment should be made. And they're also interested in making sure they're buying quality, not just quantity. So lots of interest in getting standardisation right in this sector. So one thing that I find talking to folks about data and its use is some lack of clarity about the idea of real-time and deferred analytics. A lot of people work on what I call deferred analytics. They get the data after the fact, they work out risk algorithms and so forth, but they're not very useful unless they can be applied at the point of care. So real-time analytics really takes the data that's available then and there and enables or informs decision-making by clinicians, care providers at the point of care, real time. And that requires use of data that's, as soon as the data is recorded, it then starts to provide suggestions about care. It starts to inform resource allocation hour by hour, day by day. And many of the software solutions that we have already do this to some extent, but not particularly standardized across different solutions. Deferred analytics are more a matter of interest to program managers, to the regulators, to the payers, and so forth. So they don't need to be available immediately, and but they are incredibly important. So whatever data is collected has to be available to make use of it in these two kind of time frames. I could spend a lot of time talking about that green box and real-time analytics because it's terribly problematic, and you've got to be very clever to be able to make that work well. for example, a person comes into hospital, this is one I know, so the diagnosis is often unclear and not well written down or categorised by medical staff, yet it may be a big predictor of what's going to happen subsequently. So you have to put in place a whole process to make sure that a provisional diagnosis is included in some kind of standardised format, with the opportunity to then correct it as the diagnosis becomes mature, because it may not be confirmed for a few days, and that may change everything. So that applies to all these phenomena I'm talking about. For example, continence. At the point of admission to a service, the person may appear to be continent, but 36 hours later it becomes apparent they're not continent. How do you change the record? How do you then bring it up to date so that it actually informs the care appropriately? So I think about aged care as an ecosystem, and traditionally, because of the way things are managed and also where the concentration of effort is, we have in Australia what we call an aged care system, which we think of mainly as residential aged care facilities and home care. And these are, for the most part, funded and regulated by the federal government. But old people don't necessarily see it that way. They're also accessing primary care services, doctors and others that are not within the so-called aged care system, and they're frequent users of hospitals, more frequent than any other parts of the population. So their world is not neatly compartmentalised into aged care and healthcare, it's everything. And so, as Grahame was saying, there's no integration of the data exchange amongst these systems, yet this is exactly what's needed for older people who are simultaneously or sequentially using these services and providing the same information over and over again to each of these provider groups. And they become quickly deeply concerned about the lack of sharing of reliable information, and repetition becomes par for the course. I just wanted to speak a little bit about interRAI, because this is my my kind of FHIR thing, as Grahame has been talking about. I've been involved in trying to deal with these issues of functional and psychosocial issues for about 20 years now, and working with a community rather like the FHIR community of people, about 100 people internationally, who work tirelessly to get this data standardisation problem solved. So the interRAI long-term care system is one of many systems, indeed the first that was built by the interRAI organisation. In the context of the project I'm going to talk about shortly, we're going to use it as a proxy data standard, but I'll talk about that in a minute. It comprises around about 250 data elements, like the mobility item I talked about, and it shares data elements with about 20 other systems, and I'll show you how that works in a minute. And it is the standard for recording information in long-term care in Belgium, Canada, Finland, New Zealand, and the USA at the moment, with many other provinces, states, jurisdictions, and organisations using it on some kind of a standardised basis in many other countries. It'd probably be, this would probably be used in about 10 or 20 countries at the moment. And so just to illustrate, this is the mobility or walking item in the interRAI LTCF, and you can see, looking at the left-hand panel there, that it's a fairly carefully calibrated description of how much help a person needs in terms of walking. And on the right-hand side, you'll see there is a very detailed definition for those who are, and many people are very, very diligent about the way they score these items. So there's a lot of material to help get the scoring to be accurate. Once it's accurate, then of course, it then becomes very suitable for sharing with others. So thinking about the aged care ecosystem, interRAI has built a whole lot of tool sets that would support this ecosystem. And these are the names of the various instruments that are used. And the way that the thing works is that, as this slide illustrates, there is a core data set where phenomena such as mobility, continence, cognitive function, mood, and so forth are recorded in exactly the same way with the same data elements in every setting in which an assessment is conducted. And then beyond that, there are what we would call setting-specific or program-specific data elements that only are relevant to that particular setting. So, for example, what sort of access, like steps, for example, are challenging a person is relevant to home care, but of course you wouldn't have a steps item hopefully in a long-term care setting environment where there's usually no steps for the person to be challenged by. So the idea is that the core data is the same. That means that when reading an assessment, one can understand an assessment in every setting pretty quickly, and often the data can be moved from one setting to another if the person's status is stable. And some phenomena does remain fairly stable. So, for example, hearing doesn't change very much over the short term. So that's the kind of way interRAI works. Now let me talk about aged care data compare. This is really a project that's funded by the Digital Health CRC, and I'll talk about who else is supporting it at the end of my talk. But it's responding to some of the data challenges that I've spoken about and that Grahame has spoken about. One is that there's very limited structured data available or in use around the phenomenon that I've talked about, the functional and psychosocial issues related to healthcare. What is available is not well standardised. It's highly variable among software solutions and across the various elements of the aged care and health system. There are very poor interfaces for data exchange outside of aged care into the other elements of the ecosystem. No, to my knowledge yet, articulated strategy to solve this problem. And when it comes to comparing performance, populations, caseloads, and so forth, we have great difficulty. Even within the aged care program itself, it's very difficult to say whether a person in home care is of comparable, has comparable needs to a person living in residential aged care. And so if you had the same data elements and the same ability to kind of interpret that, you would be able to kind of have a much better calibrated payment system if you were thinking about, a universal payment system for aged care, for example. We can't do that at the moment with the data systems that we have. So what this project is aiming to do is to create, working with some of the folks on this webinar, I hope, and with a group of software vendors and providers, to create a core clinical data set for residential aged care. We won't claim that that is the standard, but we will endeavour to go through this exercise to see what's there and what we should be doing. We propose to develop the technology to share this data amongst organisations based on the FHIR technology. And then the third part of this project is to develop and demonstrate the utility of a clinical benchmarking platform. In other words, we're going to, from these data elements, create a suite of quality indicators that we will then assemble into a repository and demonstrate how that can be used for clinical benchmarking. Not a new idea, but the wherewithal to achieve this in aged care is a relatively new idea. So the project, what we're calling phase one, which is the next 2 years' work, has three components. First is to create a data inventory, and that would be to look at current content of information that providers are collecting, to map, and for that matter, we'll include what the department is collecting at the moment and what it proposes to collect in the near future. We'll map that to a standard data inventory. So we're using the interRAI long-term care facility as a kind of reference standard because it does have a broad coverage of the concepts that we think will be already being collected, but it will enable us to map to those variables, sort of a proxy standard for want of something better. And then through this process to try and get some agreement amongst our collaboration of what a minimum data set might look like. And we've started work on this, is to create a FHIR representation of each of these elements and an implementation guide to support interoperability of this data. And we're planning to do this in an international context, not just an Australian context. And we're hoping, like Grahame, to lead an effort that will produce an international solution for sharing of this data. And I'll talk a little bit more about that in a moment. And thirdly, we're building a quality indicator library. The Rosa Group in South Australia have just produced a very nice report looking at the available QIs internationally. That's helping us enormously to get this work done. So we're working with them to take this forward another step to create a taxonomy of QIs and build a library, and then that will be available for our stakeholder groups to consider which of those quality indicators might be of most value to them. So we're thinking about this project as a project led by software vendors and by provider organisations, hopefully with the eye of government and other stakeholders who have a great interest in getting this right. So we're trying to get the industry to come forward with this in its own right, rather than a model where we have a top-down kind of approach to solution. What the top thinks, of course, is incredibly important, so we have to think about this from a number of perspectives. So the project phase one looks like as I've described, and then in the second year we'll construct a data hub and set up a kind of a mock benchmarking platform. We're not proposing to collect actual real data, but we will be testing this, and beyond phase two we'll be in discussions about whether organisations want to participate in real benchmarking, and we'll need to find funding and other things to do that, but that's the goal for the medium to long term. So we've got a couple of working groups, the first of which has started to meet, and then we are about to set up a clinical expert user group sometime in the next, I think we're going to meet in October for the first time. So we're up and running. We started a couple of months ago. In terms of the FHIR work, because we're using the interRAI LTCF as our starting point for creating FHIR representations and a FHIR IG, we have considerable international interest in this, particularly amongst those nations that use the interRAI toolset for their data standardisation. And particularly the Canadian Institute of Health Informatics have done some FHIR work already, but we've been talking to them about combining our efforts, and there's considerable interest in New Zealand. We're having started some discussions there. There is interest in Belgium, in Finland, and indeed all the other countries that have got some investment in the interRAI effort. So another advantage of using interRAI is that what we do will help to create an international standard, and once you get an international standard, then the investment in that standard means a much wider availability of solutions, a lot more creativity when people know exactly what they're dealing with. So that's the kind of approach that we're adopting here. So at the end of the project, we think we'll have some kind of agreement about a core data set for residential aged care. We'll start to think about home care as well. It's not that big a step to go to home care. An international implementation guide, a FHIR IG, and a localised version built for Australia, a working list of potential quality indicators, and a prototype repository for benchmarking our goals for the next couple of years. So in concluding, I just want to acknowledge the folks that are helping. I particularly want to point out that we're working closely with CSIRO, Australian eHealth Research Centre, and Brett Esler at Oradashi, being very helpful in getting the work set up, and they're going to be working on this with us. We want to acknowledge the funding from the Bupa Research Foundation, the Australian Department of Health, and of course the Digital Health Collaborative Research Centre. So thank you, George.
Thank you, Len. Thank you for that great introduction to the work. And as you pointed out, we think technical standards are hard, but once we start getting into clinical standards, we face a whole new world of pain that we need to work with. And you know, as we've discovered, especially with the growth in geriatric medicine over the years, that the number of elements required to be captured are huge. 2 points. Len commented on the Digital Health CRC. Proud to announce that the council are also members of the Digital Health CRC, and we're working very actively with them in aged care research. And one area in particular we're working on is the development of an aged care living labs network. So we will keep you posted, and there will be a future forum on that activity, but the goal is to enable aged care to play a much more active role in developing solutions and researching them and developing the evidence for their use. The second thing is that Len touched early on about his work in telehealth. I would request that you have a look at his Centre for Online Health at the University of Queensland to see a lot of the information around how telehealth has evolved over the years. Our next speaker is Stephen Strange, who's representing the Medical Software Industry Association. And the medical software industry has the challenge of taking clinical standards and technical standards and combining them into solutions that are used at the coalface. So I'm looking forward to hearing from Stephen about his experience and the organization's experience in taking the two disparate standards that are out there, turning them into solutions, and how they introduce those and implement them into the aged care provider community. So over to you, Stephen.
Good, thanks, George. Georgie, can I get my slide up? So just click through to the bottom. The nice thing about going last is that, or the not so nice thing maybe, is that there's certainly a lot of overlap about the things I was going to talk to you about. With 10 minutes, there's, I'm not going to give you a big lesson in FHIR or HL7, but it's important, I guess, to talk about our experience of it and where we see it going in the near future. But I might start with, our context, and our context is what we call the health and social care landscape, and its deep desire to interoperate with its concentric circles of influence. So think of it as the core, the center is like Russian dolls, and everything emanates from that in terms of diminishing influence depending on your context. So our definition of health and social care for us as a vendor in a particular space is that we support residential aged care. We have something like 60,000+ beds across Australia and New Zealand. And interestingly, we're one of those vendors with a lot of beds in New Zealand in residential aged care. And speaking to Professor Gray's point about interRAI, we've lived through that experience, and there's certainly interesting takeouts from that. So our health and social care landscape comprises residential aged care, retirement villages, NDIS, general home care, and what we call primary health. That's walk-in clinics and other things, more state-based funded institutions. And we put those together as the health and social care landscape, if you like, or health and social care context. And for us, the Russian dolls, the concentric circles of influence, are our health and social care ecosystem. So these words like ecosystems and interoperability seem to be popping up a lot lately, and it's really I think a failure of the industry we're most familiar with, as well as others, to embrace interoperability. We know what FHIR is, we know what's good about it, and yet in our space of health and social care, it's really not raised its head, and we're really big fans of it and as a protocol, and we want to take it into the health and social care landscape in a really, really big way. To that end, we see great opportunities and a bigger picture around what it can and can't do for us. But I might just quickly, apart from the projects we're currently working on in this space, I might just quickly touch on a cultural matter. And Professor Gray talked about real-time analytics and deferred analytics. we find it quite difficult to cajole, influence, push providers in their work practices to operate in a real-time manner. And I think the more of a big technology vision we have around interoperability and data elements changing in real time, we need to change some of the cultural practices that happen in health and social care. We struggle to get people to operate in a real-time mode at the point of care, be it due to lack of devices or spend on hardware, or for the desire never to move away from what they've always done. So not operating in a point of care mode, we see people not getting the best of what is there. And then that's just going to exponentiate once we have this real-time interoperability happening by way of enhancing FHIR and HL7. But just remember, you know, whilst FHIR and HL7 are great things, they're really evolution, not revolution. And you could even argue that if XML and similar tagging protocols were around before HL7 might not even exist. But that's kind of academic. So moving into, you know, where we see the bigger opportunities, we're working on two really important projects, and one in particular, not much was said about this in the prior two presentations, and that is around consent. So we're working on we're working with Monash University and a PhD candidate to look at how we can implement blockchain across a protocol set to enable validated, you know, consent protocols around the data that's being shared. And I think that's a really essential element that we haven't really spoken about in the context of FHIR and interoperability, because consent's just a growing issue, particularly where we see consent as even a human rights issue in terms of people looking over other people's shoulders. And the other project we're working on that's relevant to this is our open large repository, a data lake, if you like, which is going to be there for the purposes of quality and benchmarking, and very altruistically it's going to be opened to the Internet of Things, devices, open to all vendors, competitive vendors, non-competitive vendors, service providers, and it will be capable of translation as well. So these are the things that we'd really like to engage with the broader community, with the Aged Care Technology Council, the Information Industry Council, and other bodies that would be interested in participating in that. Part of the importance of, I think, being able to introduce something like HL7 and FHIR into a world, health and social care, where it's not really used, it's not really deployed, will be the need for middleware and middleware translations. So we would promote the idea of people introducing mainstream middleware tools or tools that they build themselves that are capable of consuming HL7 blocks, translating them and outputting them back in the correct protocol formats. This is going to be a really, really important part of a data exchange, and we hope that our Open Lake repository project that we're working on with, and this is also with Monash University and Deakin University with the CRC, or ARC, we hope to create what's something like a protocol exchange, a data exchange lake, which we'd really like to see extended to include the consent stuff we're working on, as well as all players in the concentric circles of the health and social care ecosystem. Now, I've spoken about cultural matters. I don't think we could ignore them. In a lot of ways, health and social care are still technologically a little behind other industries that we've worked on in terms of logistics or airlines or all those sorts of laboratory industries we've had familiarity with. Health and social care is a little bit behind the technological eight ball, and I think we need to bring it up culturally, explain the value of interoperability. I mean, the really amazing things we could do with shared care plans and assessments, charts, forms, all that data, enormous amounts of data. Our current repositories are well into terabytes. We've got, about a dozen years of, very granular data. And this is part of the desire or impetus around creating lakes. So FHIR in itself, has all these Kickstart libraries for everyone to participate. And it really does bring the web services aspect to a healthcare protocol. It does enable us to have strong web foundations at a technical level for what we're trying to achieve. That's mainly what I really wanted to talk about in terms of our perspective on it. We certainly have a big tech vision around it, and we have an opportunity to collaborate. The possibilities are endless. But if we just go to the next slide, I'd just like to say that, why bother? I mean, we already interoperate, but that's why we bother, because I think ultimately, certainly one of our missions is around the altruism that serves this sort of comment from World Health Organization last year. I love it. I tend to use it in all of my talks. We're very, very keen to see what the possibilities are in terms of bringing all the participants, all the actors, if you like, from the ecosystem into a speakable language, which it seems that FHIR and HL7 will be the logical protocol to adapt.
Thank you, Stephen.
Yeah, that's kind of my 10 minutes on it.
No, I appreciate it. Thank you very much. And like you said, it's more than just a technical challenge, and it's more than just a clinical challenge. There's a whole business model and cultural change requirements. But I think we are evolving that way. So we are seeing changes in the healthcare and aged care sector, and obviously things like royal commissions and the front pages of Sydney Morning Herald have an effect on us all. But the reality is, like you said, this is all around the altruistic goal of providing high quality care. So welcome back to the other panelists. We've got quite a few questions starting to flow through. So we probably will run out of time, but I will start off with a very basic question, which I think we've all tried to get our heads around over the many years we've been involved in this. The various silos in care still struggle to share simple pieces of data. For example, images, med lists, and they are now often locked into things like proprietary applications, be they software systems or even phone apps. Does FHIR solve this problem, assuming we can get the silos willing to share? And what else do we need to do to make this happen? I know that we could be here for days on that one, but short, sharp answers to that. I'll start off with you, Grahame.
So there's several problems that have prevented that before around IP and standards and the cost of doing that, but also the motivation for doing that. We solved the earlier problems, but in terms of making people motivated to share, it's a much bigger problem around broken markets and the way financial incentives work, and FHIR's no magic bullet for solving those problems.
Cool. Len?
Well, I think what we're trying to do is, obviously get a language of, I've talked about functional and psychosocial issues, which are, really central to aged care. So they're the piece that those of us in aged care about. But these are also a very big piece of acute care and primary care as well, although they're not the whole story there. So trying to find a way to at least share the data that is collected in an aged care setting with the other sectors in a granular format, enabling it to be recompiled in a manner that's suitable for use in each of those other settings is our aspiration. So if you imagine a person moving from residential aged care goes to hospital, the kind of profile that a clinician would want to see when that person arrived at the hospital would be different than the one that the users at the RACF would want to look at, but it would be compiled from the same set of granular data. So we imagine a future where the data elements can be shared and recompiled in a format that's useful to the receiving. So the same thing about each of the stakeholders or participants in a care plan want to see a different image. So I think that's where I see the FHIR ability to kind of share data at a granular level as well as at a composite level is very attractive from that point of view.
Thank you. And Stephen?
Yeah, same. The attractiveness of being able to share meaningful data at a very granular level is something, you know, we've been kind of contemplating for a while, and we also concluded that FHIR was the way to go.
Cool. So we've got another question here. It's probably a bit more technical. What is the role of digital signatures, keys, and certificates in FHIR-enabled systems? Do we need to change that aspect of our current systems to enable us to use FHIR? Probably start off with you on that one, Grahame.
Well, FHIR as a web spec works generically with any web certificates and so forth, but typically a community will form and agree about which particular security approach they're going to use. This is particularly difficult here in Australia because we've spent so long pursuing basically a non-web strategy with secure messaging. I finally snapped and gone public and said in public that we really need to think again with our strategy, but everybody's going to argue about certificates and who pays for them and so forth. But the real problem is actually in scale. The real problem is matching humans to certificates, and that's where a lot of my thinking is around. Is how do you solve the economics of that problem?
Then,
Steve, would you like to add to that?
Yeah, well, our approach at the moment is looking at blockchain as an economic solution.
Cool. Actually, that does, because we've actually had a couple of questions about how this all links in with blockchain. So do you want to iterate a bit more on that, Stephen?
Well, I mean, they're not competing things. You can melt your HL7 protocol support with a blockchain wrapping for. At the end of the day, blockchain is just a consent protocol. You know, it's not a granular data interchange protocol. Although there are some overlaps, it's relatively simple to implement the blockchain, but still support the HL7 protocol. It's not a difficult technical exercise. It's a matter of saying, well, will this pervade applications, devices, etc. And that's I think the difficult hurdle to jump, not so much the technical stuff.
Cool. I think we have plans for a future forum to include some discussion on blockchain because it's come up a number of times in various discussions. A question for you, Grahame. You noted that Apple provides a validation service for FHIR. Can you go into more detail about how this evolved and whether the other platform players, i.e. Google, Microsoft, and various Linux and Unix flavors are also involved in that sort of validation process?
So there's a public validation process which I manage. I actually code the validator. The economics of the way it works is very specific to Apple. They are operating a mass consumer service that needs to work, bulletproof work. Whereas Google and Microsoft's business in healthcare is very much institution focused. So they go to an institution and says, what data do you have? We'll deal with what you have. Whereas Apple goes to the world and says, here's how it works. We'll check that you work this way. And so the economics are totally different. So Apple's service that they run is something they worked up internally to check that their consumer level services will operate whatever. And it's an amazing scale that they work at. A totally different way of thinking around quality because of just the scale of their work. And it was a big lift for the vendors initially to get used to the Apple way of working. So the Apple validation services are you know, basically they write a function internally, and then they write a validation service that validates that the services they depend on work that way. So Apple are working alone on that, but I talk to the Apple team and they feed me, privately, they feed me information about what we need to add to the validator for general testing. So it's as good of a process as we can figure out how to make it.
So access to your validation service is available online. I guess we'll share that with people at the end who are more interested in the technical specs. But people are actually asking, how do they get more actively involved with the FHIR community? So both from a technical perspective, do they need to be members of HL7? Do they need to do a course? Grahame, any recommendations on how to become a FHIR person?
There's really, it's really a scale. You can get involved by hanging out on phone calls and listening and contributing when you have a chance. You can get involved by sending engineers along to contribute to the core discussions, to take part in connectathons. Probably the most appropriate thing from what I've heard today is to get involved with the Lens project around the data, to test, to contribute, to provide knowledge. And you can do, there is online tutorials, both free and paid, which you can do if you want technical knowledge. There is industry events that are targeted to newbies to, teach you about how to get involved. In this day and age of social media, it's all over the place. There's so many different channels that we try and keep on top of. I encourage people to spend some time one way or another. But as I said, the project Len Gray is talking about, I hadn't heard about it before. I'm really glad I was here to hear about it. Len, I'm going to email you about how to get it more integrated into the wider Australian work and the community. Well, that really sounds like a great place to work.
Well, it's good to see the council has done its job in making sure the right people speak to the right people to make things happen. Yeah. Stephen, from a vendor's perspective, I mean, implementing FHIR within your organisation, what sort of challenges did you face, and what did you guys have to learn to come up to speed?
So it's a bit of a work in progress, but I just want to support what Grahame said as well, that I think Lens project is a real key to getting us across the line. And one of the things we're facing here is some of the concentric circles of influence are not technologically up to speed. A really good example, and I don't want to offend anyone, but the pharmacy world is quite disparate, and in disparate rates of technological adoption. So that's been a big challenge for us, is to get those protocols common, and to try and figure out what that common set of denominators are for that world. So that's been more difficult than sort of saying, assessments, care plans, charts and forms. There's a lot of common denominators there. I do think we've got to be a little bit careful about the concept at a sort of a meta level of common denominators. We don't want to lose granularity and nuance, because that can happen at times.
So I think there's wide supports for Lens. So if there's any funders out there who want to support Lens project, I'm sure Len will be happy to speak to you. But Len, any comments about what made you choose FHIR? I mean, it's not like you're a deep down technical HL7 guy. And
well, that's been I've been well aware of the FHIR opportunity for several years, and I guess a number of people have talked to me about it. Obviously, the folks at CSIRO eHealth are very FHIR savvy and capable, and so we collaborate on many things. So it's just a logical. And of course, the other thing is that there's in my interRAI world, which I'm very connected to many people in many countries. There's about 40-50 vendors worldwide that build interRAI solutions, and they're all a large number of them want to be involved in our project to get the same FHIR standard. They want to see an international FHIR standard for interRAI. So it's a huge footprint that we can take advantage of. if we go down that track. But so there's a whole lot of reasons. It's a coming together of some influences and ideas.
Excellent, thank you. So the next question here, Grahame mentioned that there are trials with care plans and pilot projects with FHIR. How would you get involved? Do we need to know IT guys and developers? And just before you answer that, Grahame, I just put again another plug in for the Aged Care Living Labs network, which is being developed through the Digital Health CRC. So any aged care providers who are keen to get involved in pilot projects, the goal of the Living Labs network is to enable you to do that without having to go through all the heavy lifting of developing infrastructure and frameworks. So we're happy to do that. And obviously there's a lot of interest in FHIR related projects. So to those from the Digital Health CRC in the listening, well, it will be something we will be discussing at our next meeting on Thursday. Over to you, Grahame. How can they get involved? Other than joining LED's project, obviously, which is, by the sounds, it's going to be hugely oversubscribed by the end of today.
The projects that I talked about are all international projects. That, you know, and they're very, very regionally focused. Typically a city or a sub-part of a city where some, you know, clinical champion says, I want to set this up, and corrals all the vendors with political support one way or another. For a variety of reasons, we've never been able to bring all the pieces together for that in Australia. Certainly the digital CRC is, you know, the first and most obvious channel, and I've spoken occasionally to the digital CRC people, but so far I haven't heard of projects emerging. That's not the same as there are none. There's also in Victoria, the Melbourne Uni's busy setting up a Validitron project, which is really another little ecosystem in which you could evaluate, you know, small focused projects around how to improve healthcare outcomes. I haven't heard any talk about aged care in the Validitron, but I think they'd be receptive to that. Some of the other universities are doing similar work, and so they should be. And then more generally, if you're interested in the GP interaction as well, Len just talked about the CSRO project. They're running a very active project around a GP ref set, data set, to make it easier to move records between GPs. But that's still a very general project rather than a specific focused healthcare process project. And as I said, I wish there was more of them here in Australia.
Len or Steve, you'd like to add anything to that?
Yeah, look, one of the things I forgot to mention earlier was that, you know, we've got to target moving away from these coded interoperability solutions. I mean, we've got a number of GPs that talk through our world, but it's coded, you know, and at best it's using translation mediums. If we can all kind of sort of say, right, you know, from this day forward, you know, these are the protocols we're going to use, and these are the standards we're going to use. That's going to make real light work of what we're trying to achieve with, again, these, you know, participants in the concentric circles, the GPs, the allied health professionals, the devices, you know. You know, we've got to get away from the idea of these people are still leaping to coded solutions.
Len, any comments?
I need to say that, yeah, obviously the experience that CSIRO has had with the primary care project, which is now in its second or third year of evolution, we're obviously learning from that experience and trying to replicate some of the successes it seems to be having. It's certainly got good engagement from the vendor community and from the general practice community. They've got a very complex set of clinical phenomena they're trying to characterise. Of course, it's indeed much more difficult than aged care, I think, in terms of the breadth of things they've got to attend to. But so in a sense, we have an advantage with where we're up to in terms of the data elements. But yeah, I think we're learning from that experience. We're going to try and bring these groups together eventually, so that we think about these. You think how important it is for the relationship between primary care docs and RACFs, and for that matter, how doctors relate to home care programs. They're just other worlds from what I can figure out operationally. That should not be the case. It should not be like that at all.
Yes, the siloed nature of care systems in Australia are something that we've been talking about for many, many years. And whilst we're seeing some improvement, it is slow. We do have one suggestion here for your project, Len. It's from Janine Carter, to the involvement of health information managers within your project as well. So I'm sure Janine will put her hand up to give you some advice around how health information managers who play a vital role in our health ecosystem today can play a greater role in the project. Another project question that's come up, and it's a combination of 3 or 4 questions. So in the early days, Grahame, when HL7 was moving from the version 2 to version 3s, we had a huge blowout in the amount of data. And now as more and more people are moving their data to the cloud, moving data, storing data is becoming a major issue for a lot of providers. Does FHIR increase, decrease, change at all the amount of data that's being stored, and obviously how it's being transmitted? Is there anything we need to keep in mind when we're developing systems from a data volume security perspective?
Well, look, I mean, that's a complicated answer. So expressive formats that are easy to work with are also verbose formats. There's no, that's how it is. So FHIR certainly is a verbose format, and people have fooled around with much more concise representations, and there's still some interest in that. But in the end, it turns out that paying programmers is more expensive than paying for storage, typically, and so it just hasn't attracted that much interest. But absolutely, it's certain that use of FHIR will increase the amount of data that's exchanged and stored. There's no question about that.
Our last forum was on cybersecurity, so obviously that also raises the issue of how we encrypt the data in transit and how we manage the data in storage. Unfortunately, we have run out of time. It's been a fascinating discussion, and we have a heap more questions. But the good news is that I'm sure if we switch to the next slide, Georgie. We'd like to announce that as of today, the new Aged Care Industry IT Council group has been formed on LinkedIn, and we actually now have a platform for ongoing discussion about many of these topics. And I'm sure Stephen, Len, and Grahame would love to join us there for some discussion. So we look forward to an ongoing discussion about this topic. It is evolving. You said the Aged Care Industry IT Council is specifically looking at how we use the technology innovation to improve the quality of aged care. Please join me in thanking our 3 speakers, Grahame Grieve, Professor Len Gray, and Stephen Strange. Big virtual clap in the background there, guys. You can probably hear it rebounding through your headphones. We look forward to seeing you all at our next national forum. Please join our LinkedIn group so you can keep in contact with us. We do send out emails, but one thing we are discovering is that email is probably no longer the best way of sharing information in this world. But today's been a fantastic session. I've learned a lot, and I've been doing this for 25 years. So those of you who want to play a greater role in the use of FHIR in aged care, join the LinkedIn group, contact us at the council, get involved in the Living Labs projects as we go forward, and we look forward to improving aged care in Australia. So when the Royal Commission provides us a report, it will basically tell us that they learned so much from this forum that that's how we're going to change aged care. Thank you, everyone.